Hi everyone, my name is Faustine Ramirez and I'm a master tutor with MedSchoolCoach. And today we'll be reviewing a Step 2 CK OB-GYN question. So let's start by reading the stem. A 26-year-old gravida 2 para 1 woman at 37 weeks and 2 days gestation is admitted to the hospital in labor. She had spontaneous rupture of membranes 4 hours ago. Contractions are moderately painful and occur every 4 to 5 minutes. She received routine prenatal care and has had no problems during the current pregnancy. Her blood type is O positive and the father's blood type is AB negative. Prenatal labs were all unremarkable. She has no past medical history and takes no medications. Her previous pregnancy was uneventful, but her older child was treated for GBS meningitis in the first week of life. Her temperature is 37.5 degrees Celsius, heart rate is 85, respiratory rate is 17, and blood pressure is 124/72. The cervix is 5 centimeters dilated and 70% effaced, and fetal monitoring demonstrates a Category 1 fetal heart tracing. Which of the following is indicated at this time? So I'd like you to pause the video and try to work through this question on your own first. All right, welcome back. So let's approach this question together. So as always, the first step is going to be to read the very last sentence to read the question itself. Which of the following is indicated at this time? So this is going to be a management question. And we glance at the answer choices next very quickly. This should only take you a few seconds. And we see that it involves a combination of interventions, procedures, medications. Most of these are medications. So this will help frame how we read the question stem, but a lot of these are in different categories. Some are antibiotics, some are medications used in labor, some are tocolytics, and some are interventions. And so we'll have to keep an open mind as we're reading because it just doesn't really clue us in as to what the question is going to be about, because these are all very different types of answer choices. So it's just helpful to glance at these answer choices before reading the question so we have an idea of what some of the possibilities are going to be, and it helps frame how we read. So let's read from the top and highlight the key elements. A 26-year-old G2P1 woman at 37 weeks and 2 days gestation is admitted to the hospital in labor. She had spontaneous rupture of membranes 4 hours ago. Contractions are moderately painful, occur every 4 to 5 minutes. She received routine prenatal care and has had no problems during the current pregnancy. Her blood type is O positive, and the father's blood type is AB negative. Prenatal labs were all unremarkable. She has no past medical history and takes no medications. Her previous pregnancy was uneventful, but her older child was treated for GBS meningitis in the first week of life. Her temperature is 37.5 Celsius, heart rate is 85, respiratory rate is 17, and blood pressure is 124/72. The cervix is 5 centimeters dilated, 70% effaced, and fetal monitoring demonstrates a Category 1 fetal heart tracing. So before we go on to look at the answer choices, a few things to pay attention to for OB questions. Are going to be the frequency of the contractions, the timing for the rupture of membranes, any prenatal labs. So here the mother's blood type is important, any past medical history. Vital signs here are all normal. If they were abnormal, I would recommend highlighting them. And then the cervical change is important to pay attention to and to know what stage of labor that corresponds to. So if you can't remember what the stages of labor are and what that corresponds to in terms of cervical change, the dilation, effacement, I would pause the video for a moment and take a moment to review that before proceeding with this question, because it's important to know what stage of labor we're in and how quickly we would expect a woman to progress through labor. Contractions occurring every 4 to 5 minutes are certainly starting to be more regular. And so this woman has regular contractions leading to cervical change. And so she meets the definition for being in labor. And in terms of fetal monitoring, a Category 1 fetal heart tracing, this is meant to try to trick you, but this is actually a totally normal tracing. The categories are 1, 2, and 3, and a Category 1 fetal heart tracing is a normal, reassuring, reactive fetal heart tracing. So let's take a look at these answer choices. So which of the following is indicated at this time? So there's no specific necessarily a diagnosis that jumps out at us when we read this question. So this is not the type of question where you need to identify what the diagnosis is and then answer a question about it. It's more about assessing a situation and seeing what has been done so far and what needs to be done next? So it's definitely a management question, but it's more about managing a particular situation. And so here it's managing a situation where the woman is in labor. And so the question is about what to do next. And so you have to kind of assess the information you're given in terms of the prenatal labs, in terms of the contractions, the cervical change, any other important pieces of information in the stem, and decide which of these items you need to act upon, if any. Oftentimes these questions will also have the option of not doing anything. So it's also important to know not just what's abnormal, but what also is normal. So that's why I really encourage you to know what is the normal progression of labor, what is the normal frequency of contractions, what is the normal expected cervical change, because sometimes the question stem will be entirely normal and you just have to choose no intervention needed. And sometimes there will be some abnormal elements and some normal elements, and you have to know which ones to act upon. So this is that type of question. And a lot of these questions do come up in OB. For example, they come up in pediatrics with kind of routine well child check, healthcare maintenance things where you have to know what's expected and what's abnormal. What do you need to act upon? So now let's work through these answer choices. And if something jumped out at you as we were reading the stem and you already know right off the bat what the answer is, that's fantastic. And you don't need to waste your time reading all the other answer choices and thinking about them. If you already have an answer in mind, I would just go ahead, pick that one. Certainly, you can glance at the other answer choices to make sure that you haven't missed anything super obvious that perhaps you didn't catch when you were reading. But for the most part, if something jumped out at you already and you know exactly what the answer is, I would just pick that one, be confident with it, and move on. Now, if you're not sure what jumped out at you in the stem as being the abnormal component, then it's important to work through the answer choices and eliminate them one by one. So let's do that scenario where we're going to look at the different answer choices and we're going to use process of elimination to get the correct answer here. So A, urgent cesarean section. So based on this fetal heart tracing, which is reassuring, and based on the fact that there is appropriate progression of labor with appropriate cervical change in the setting of regular contractions, and otherwise mom is hemodynamically stable, baby is stable based on this fetal heart tracing, there's no indication for an urgent C-section. So we can cross that one off. Betamethasone. So this is testing your knowledge of what the indications for betamethasone are, and this is going to be given to any mother who is at risk of going into preterm labor or who's in labor less than 37 weeks. And so this mother here is at 37 weeks and 2 days, so she does not meet the criteria for getting betamethasone. So we can cross that one off. Tert-butylene. So tert-butylene is a tocolytic. This answer choice is testing your knowledge of the fact that tert-butylene should not be given, and any tocolytics, in fact, should not be given beyond 34 weeks. This is contraindicated. So depending on which tocolytic, they're contraindicated beyond 32 to 34 weeks. And so this woman at 37 weeks, once she gets to term, she's at 37 weeks, there's no reason to delay delivery. There's no reason to stop her contractions, which is what tocolytics do, because she's at term and this baby can be born now. So this is wrong. RhoGAM. So RhoGAM, this is testing your knowledge of the indications for giving RhoGAM. So remember that RhoGAM is given to mothers who are Rh negative. It's given routinely to women who are Rh negative at around 24 to 28 weeks, and it's also given within 72 hours of delivery. So a woman who is delivering a baby who's Rh negative should get RhoGAM to prevent future pregnancies, to prevent alloimmunization in future pregnancies. However, this mom is O positive. And even though the dad is 8B negative, that's really irrelevant. That's there just as a red herring. So this, again, was testing your knowledge of the indications for RhoGAM, which are for women who are Rh negative, not positive. So cross that one off. Penicillin. So this is testing your knowledge of the indications for penicillin antibiotic prophylaxis for GBS. And so we're not told anything about the mother's GBS status specifically, although we are told that prenatal labs are all unremarkable. So we can assume that she's GBS negative in the current pregnancy. We are told something about GBS in the previous pregnancy, and so we may not know exactly how to interpret that. So let's hold off on that one, and we'll come back to it. Um, Misoprostol. So misoprostol is used for cervical ripening to help with cervix changing in either in preparation for induction of labor or augmentation of labor. But here we're told that the cervix is changing, is making appropriate cervical change in the setting of these contractions. She's already ruptured her membranes. She's progressing well with 5 centimeters, 70% effaced. So there's no reason to give her misoprostol at this time. Magnesium sulfate, cervical ripening here. So magnesium sulfate, this is testing your knowledge of the indications for magnesium. So magnesium is used for neuroprotection and is also a weak tocolytic, and this is really used for more preterm infants less than 32 weeks. And so there is no indication to give magnesium. This mother's at 37 weeks, and there's no need for neuroprotection when she's this far along. And there's, again, no need for any tocolytic action. So that is incorrect. And then lastly, no intervention are indicated. So this really comes down to E or H. So we really need to know all the specific indications for GBS prophylaxis in order to answer this question. So what this is getting at is some of the more nuanced indications for GBS prophylaxis. And these are very highly tested, and I can almost guarantee that you'll have a question on this on your exam. So let's review these indications and see, then we can come back to the answers and determine whether it was E or F. So indications for intrapartum GBS prophylaxis. So the first one is probably the most obvious one, is if you have a positive culture in the third trimester, and we usually do a rectovaginal swab for these at 37 to 35 weeks, and that is kind of part of the routine screening that's done in the third trimester. This is when moms get tested for GBS in the current pregnancy. This is when it happens, and if that third trimester culture is positive, they should be treated intrapartum with antibiotic prophylaxis. The next indication, and the only exception to that I should mention, is that if the patient is going to have a C-section before the onset of labor when she still has intact membrane, so there's been no leakage of fluid with potential transmission of the bacteria into the amniotic sac, potentially exposing the fetus to GBS bacteria. So if the patient has a C-section before she goes into labor with intact membranes, at that point, you don't need to prophylax for GBS, but they'll probably get antibiotic prophylaxis intraoperatively just as part of the surgical prophylaxis, but they don't need GBS prophylaxis in this specific scenario. The next indication is if the mother had either GBS bacteriuria or GBS UTI at any point in the current pregnancy. So remember, in the first trimester, women have a urine culture. So if that, as just part of routine screening, so if that urine culture grows GBS in the urine, so bacteriuria just means growth of bacteria in the urine, even if she's asymptomatic, or if she has a symptomatic UTI at any point in pregnancy that also grows GBS. So at any point, GBS growing in the urine, either symptomatically with the UTI or asymptomatically on routine screening in the first trimester, that would also be an indication for intrapartum antibiotics. The third one is a history of a GBS neonatal infection in a prior pregnancy. So this could be sepsis, this could be meningitis, any type of neonatal infection in a prior pregnancy is an indication to use intrapartum GBS prophylaxis in all subsequent pregnancies. And so this is what we're referring to in the question 7. We'll come back to that. But ultimately, this is the point, the nuanced point that this question was testing was your knowledge of this specific indication for GBS prophylaxis. So in this mother who had a prior pregnancy where the baby had a history of GBS meningitis in that first week of life, that would be a sufficient indication for GBS prophylaxis in all subsequent pregnancies that the mother has. And then finally, if the GBS status is unknown and the mother meets one of these following criteria, it's also an indication for GBS prophylaxis. So the first one is less than 37 weeks gestation. So if the baby is born preterm, less than 37 weeks, usually we the mother's GBS status might not actually be known if the baby's born preterm, because if this is not done until 35 to 37 weeks, we might not know what the mother's GBS status is. And so preterm infants are at increased risk of all neonatal infections, including GBS. And so we routinely give mothers intrapartum GBS prophylaxis if their status is unknown, less than 37 weeks. Another one is rupture of membranes for 18 hours or longer. 18 hours is kind of the cutoff we use for prolonged rupture of membranes, which increases the risk of infection both to mother and to baby. And so that would also be an indication if GBS status was unknown. And finally, if mother's GBS status is unknown and she spikes a fever intrapartum, that makes us concerned about chorioamnionitis, and that is a risk factor for neonatal infection and lots of other adverse outcomes in the fetus. And so we would also prophylax with antibiotics. And so this is a question about indications for GBS prophylaxis. And let's also just take a brief moment to review what the preferred antibiotic choice is. Do you remember? So it is going to be IV penicillin is our first line antibiotic for GBS prophylaxis intrapartum. So this is really important. And all these indications, albeit very granular and nuanced, you must have all of these memorized and they will be tested. So returning back to our question, finally, we look at the other answer choices, E and H. So we are told that the mother had a previous pregnancy where the child was treated for GBS meningitis in the first week of life. So this meets that indication number 3. And so this mother should receive penicillin in this current pregnancy. And so H is incorrect because she does meet criteria for GBS prophylaxis. All right, so that wraps up our question of the week. Thanks so much for listening.